All right. So we have a panel. You know all of the experts up there on the panel. You've heard them speak. Who's new to you probably is Dr. Mitchell, who has joined us. And you've heard us speak about him and the inspiration he's given us and the innovations he's had to advance the field of bladder exstrophy. So we're very privileged to have him up on the podium with us today. And I would like to start with questions from the audience because this is about you guys, and this is an opportunity for dedicated time to ask questions, okay? Did you want to start, Becky? And then I'll come to the gentleman in pink.
So to start with, I'm a patient of Dr. Mitchell's from Seattle. And to just start with setting the stage for you guys, I void naturally, and I am completely continent. And when you were talking about the long-term aspect of things, and the bladder starts to deteriorate around the 20-year mark, I'm hitting the 20-year mark. What am I looking for? How will that present itself, and what do I do? I don't have a Mitrofanov, I don't calf. So if I have an issue, what do I do?
So the data that I was presenting isn't saying that it's going to start at the necessarily 20-year mark. It's just showing that the data that we had is, these are some data from like when some of these patients are 20 years out. So I do have several patients that are similar to you that I've inherited from Dr. Mitchell over the years that are, on the, because it's a spectrum on how individuals do. So they're, on the very high end of the spectrum doing well, volitionally voiding, continent of urine, and are in their 20s there. So the things that you're going to look for, which would be signs of incomplete bladder emptying, or would be like, I feel like I have to strain more to urinate, I'm getting more urinary tract infections, having more accidents, having abdominal pain. So those are the things that you're going to look for. It's not saying that it's going to develop, but that's there. So now you're saying like, I'm leaking throughout the day, and then I, have to strain more, feel like I'm doing a sit-up to void. That's where you need to be evaluated if you are emptying. And so in those individuals, that's where the muscle just stops, loses that ability to contract as well. But that's how you'd follow it. And if anybody else wants to, and then also that's where you have routine follow-ups looking for ultrasounds. Exactly. and with new hydronephrosis and things like that.
I was just going to underscore exactly what Dr. Groth just said, which is don't stop following up. That's all. I don't want you to be, you should be really happy that you had a great surgery and you're doing great. I mean, that's really great. I mean, that's where we want all of our kids someday. We hope that they'll all be like you. So I don't want you to live in impending doom that something could happen. But at the same time, you have to be cognizant that you can't just stop like, oh, everything's great, I'm normal forever. I mean, we are normal, of course, but keep following up every year. Get an ultrasound. Like you said, UTIs, suddenly you feel like I'm just not emptying. If there's ultrasound, shows some fluid backing up in the kidneys a little bit, don't take it lightly, stay and follow up. If you're having any trouble, call pediatric urologists. They'll point you to an adult urologist. But go to someone who's transitional urologist who will continue to follow you and do those things. But overall, great, and that's awesome. And you don't have to live with something bad's going to happen anytime. But just keep following up.
Yeah, I would underscore that risk of long-term bladder deterioration is something that keeps us up at night as urologists, but shouldn't necessarily keep you up as people living with exstrophy. It's our job that as long as you're coming in for regular checkups, whether you're doing well or not doing well, and being open and honest with us about how things are going, that's kind of our job to make sure that we're checking those things and that we're not sacrificing future health for maintaining current status if there's a problem that we can see.
Hi, good afternoon. Just for new people that have come to this conference, I just want to stress that that's like the dream team up there of urologists. I can't tell you enough how fortunate we are to have this amount of expertise in one room. Our journey started in 2002, and I can tell you what, it was kind of hard to find information and find out, just about anything related to this this topic. But two quick questions and more in generalities. I'll just ask, what do you know about an augmented bladder and high amounts of ammonia in the blood when there is some sort of bladder infection, UTI? And then generality of, has there been anything to help prevent bladder stones with an augmented bladder going forward?
Would somebody like to begin with that?
So I do take care of a lot of adult patients with augmented bladders for other diagnoses as well. The number one thing that we stress is irrigation. And maybe if you're doing it one time a day and you're still getting stones, you might have to do it twice a day. And if you're still getting stones, you might need to get some images to see if there's any pockets within the augmented bladder where the irrigation is not getting to. Then you might need some type of imaging for that or a camera to look. But the number one thing is irrigation. To make sure that the mucus doesn't build up and come together and form stones.
In addition to irrigation, we use a little bit of vinegar in with the solution. So a tap water solution of about 1 ounce of plain white vinegar to 500 milliliters of tap water instilled into the bladder in a small aliquot then at night can help reduce crystallization of stones, the matrix of stones within the bladder. Were there other, you had two-part question. Oh, and now I'm talking about vinegar, right? And acetic acid, right? Ammonia in the blood.
A lot of agreement with vinegar here on the table, so I think it's something to think about for sure. In terms of augmented bladders, also very similar to what I just heard. More than anything, what can sometimes happen is as the young adults get older, somebody born in 2002, in 10 years, you're doing great, you're in control, you're dry, you're happy, and it's easy to lose follow-up. And the biggest thing with augmented bladders is, I think, regular follow-up now there's no good agreement, but say 5 years, 7 years of cystoscopy, taking a look, making sure the lining looks good and healthy, or at least every 10 years. Things like that should stay in, and get an ultrasound, I think, annually. Stones are, especially if you've dealt with stones, they can sneak up on you and get bigger and bigger. And we've seen, people who sort of lost follow-up just say, I think I'm doing fine. I mean, people with, I'm talking, very well-educated, smart people, but life takes over and you're doing great. And I have seen stones get very big and even affect kidneys. So I think that regular follow-up lifelong is critical. Looking for, the blood, acidosis, infections, all of those things staying in the front end of that.
I don't know if many people think that using normal saline is better than water, boiled water. And that Tony Curry did a nice research in Toronto and showed that the best way to irrigate is actually water. It's not normal saline. And at least I had some patients that always been thinking that normal saline would be the best way to irrigate. Actually, it's not. It emulsifies better the mucus. Another thing that is important, if you have an augmentation, you have to drain the bladder with an adequate catheter size. Now, catheter number 14 is the ideal one for draining. If you are using a number 10 in an augmented bladder, you're probably not going to evacuate the mucus well. you're probably going to have more UTIs. So you have to try to use a larger catheter. I like to use number 14 in augmented patients to drain the mucus well and to drain the bladder well. So you prevent not only stones, but you prevent also infections. And also in some patients, changing a little bit, they can, with an augmentation, sometimes they can make a pocket, and the mucus can stay in the pocket, and they can form a stone. So sometimes changing position a little bit, you can sometimes displace a little bit the mucus and drain better. So the important thing is to drain the mucus very well.
Related to the ammonium question, I always have to rely on my younger colleagues to correct me on my physiology if I say something off topic. So Lizzie, she's ready to listen to what I say. But there's going to be more ammonium secretion from the augmented bowel with a hydrogen ion, which can lead to some acidosis. And you have to be careful with acidosis and watching the acid-base balance in the bloodstream to minimize bone resorption. And so you do need at least annual blood tests for electrolytes to ensure that you're maintaining the appropriate acid-base balance in the bloodstream. And sometimes, and not uncommonly, supplements are necessary to maintain that, but the ammonium levels themselves, the ammonia levels in the blood should not be higher.
Yeah, I mean, you're right, John. I think the ammonia level question is more when it intermittently spikes, and that would be from urate-splitting organisms, which are certain kinds of bacteria. And so when you're augmented, when you're non-augmented and you have these urate-splitting organisms, it's just a UTI or kidney infection. Sometimes it increases your risk for stones, but not an elevated ammonium level. However, if you're augmented and you have those organisms, in some individuals, you can then absorb it. And then that gets in the bloodstream and elevates the ammonium in the blood level. So it's really because the GI, the intestine that's in part of the augment can absorb that. That's why you're getting those spikes. But it's also important with the acid-base things, and that's why frequent patients are followed with nephrology for supplementations and things like that, because there can be acid-base disturbances.
Hi, so we have gotten so spoiled with MIBEC and the fact that our kiddo has grown up with the MIBEC community. But at some point, she's going to outgrow pediatric urology. So I hear all these emphasis on the importance of continuing care, and you guys have developed this amazing community and this consortium. What sort of have you developed in terms of resources of handing off to adult urology or handing off to fertility specialists or any kind of teamwork at that level?
One thing that we have at CHOP, which is not yet a MIBEC situation, is that we do have an adult transition urologist who is at the hospital with us. He's in our clinic. He sees patients starting at age 14, 15. We'll have patients start meeting him. And so you get to know the sort of the next generation of physicians. And by having an invested person who's seeing, I'll say, kids at CHOP, he continues to see the same kids at CHOP until their 30s. And so if you're still plugged in, then you could say, well, you can either go over to the adult hospital, which many times people are like, yes, we don't want to have elephants on the walls. We want to go to the adult hospital at some point. But you're still plugged in, then we would say, hey, keep on coming to MIBEC. But there is overall and nationally a very much increased push towards transitional urology and incorporating that transitional piece of having adult reconstructive trained urologists start seeing pediatric patients so that they know them. Now, I think it's something that we'll all have to discuss. We just did our 10-year extension to follow kids from 10 to 20. Probably all our institutions will share and have the same thing.
So I know that I was supposed to be optimistic and glass is half full kind of thing, but with transitional care, when I'm preparing my 18, 19, 20-year-old patients to see adult urology colleagues, I am very pessimistic when I say see an adult urologist, because the reality is only select adult urologists really understand the type of anatomy and type of surgeries that typically exstrophy epispadias complex patients undergo. I think it's our responsibility to identify key providers that are willing to see our patients and that there is a seamless transition. And should there be surgical needs, that we collaborate with our adult colleagues. But the reality is, when we transition adult patients, we want to be done and with the surgeries or major surgeries and transition patients when they're stable medically. That's, I think, all of our goals. And for our adult colleagues, I think it's kind of a lot of medical management, and adult urology practices aren't really set up like that. So I think as a group, we may have to kind of think about creatively about transitioning our patients in a more seamless manner, and we could perhaps be a model for that, and that is maybe our 20-year goal.
What about at Children's Wisconsin? What do you guys do?
So we have really good relationships with our adult reconstruction colleagues. And I think that the most critical thing, and you heard it here, is that we need to find and identify urologists that have maintained a sense of curiosity, a sense of collaboration, and wanting to learn. So we have a great team that we have had successful transitions for other complex reconstructive needs. The majority of our bladder exstrophy population is fortunately not needing that yet, so the immediate pressing need for most of our MIBEC cohort is not there just yet. But it also probably is involved in, and I think that you heard Dr. Weiss reference this, there is a growing recognition within our field as well as within a lot of fields, so that as we learn to do better care and achieve better outcomes for children that are born with complex conditions, that there is and will continue to be an increasing need to educate future doctors who know how to care for adults with those conditions. And I don't think that's unique to bladder exstrophy. And I think that we continue to aspire to do that within urology, but a lot of other fields also are working on that. And so we don't necessarily have to reinvent everything about it, and we can borrow some of the best ideas from congenital heart disease and other models of care that exist.
Yeah, I was just going to say, there's an entire specialty area now, congenitalism, where in urology. So there's scientific society, scientific meetings prioritizing this. So I want you to know, again, I'm always sort of the optimist that this has really become a focus for us as well, because, and I think what I would suggest is an institute, like a Medical College of Wisconsin, Boston, CHOP. What's good at a university, like an academic center, is that we pay the salary. So an adult urologist comes to CHOP once a week and sees these patients with us for about 2 years together. And then there's a slow handoff where I start backing off and you go. But that doctor, he will always call when he has a 38-year-old with a Mitrofanov problem with a history of exstrophy. He calls us and says, hey, why don't you come on over across the street to the adult hospital and be here as we do this. So I think those are types of relationships, and I know we're not the only ones. I know in Chicago there's that relationship here. So, where these institutes where we share an academic home, we can go over to where we have, privileges at the adult hospital next door. They have, that doctor has a privilege at our hospital. And so this is top of mind, and so I think we'll be, look for the right place.
Yeah.
You might have to do some searching,
Yeah.
but they exist.
Thank you. Dr. Mitchell, you had given me kind of a unique perspective into how you had interpreted the embryology of the bladder exstrophy defect or malformation, better choice of words, as a herniation of the pelvic organs through a defect in the abdominal wall. Can you elaborate a little bit on that and how that maybe inspired you to view a complete reconstructive surgery in infancy as a key to long-term bladder health and continence?
Which part you want me to answer first?
I'd start, I was making it broad and giving you a choice.
Okay.
But what about the embryology
Okay,
of
the embryology is, yeah. We, a long time ago, I went away on vacation, and my residents were to choose a topic of research. So they decided that they wanted to look at hernias, and they took a chick embryo and they used a laser. And when I came back from vacation, I asked them, well, how was your project going? And they said, well, we did this thing to the chicks, and you should see them. They look they look awful. And so we went to the lab and we looked at these little chicks, and they had exstrophy, the bladders of the. So basically, a long story. We look at the etiology of exstrophy as a single hip phenomenon, and it involves the infraumbilical ligament or membrane that serves as a template for the closure of the abdominal wall. And if you lose that template early, then the abdominal wall doesn't close, and you wind up with exstrophy. And the spectrum of exstrophy just depends on when you lose the infraumbilical ligament or membrane. So it was a long story, but it was a total accident, but made a whole.
Dedication and passion is where the opportunity for innovation comes from. I was just going to say dedication and passion and being there is what creates the opportunity for innovation, right? Recognizing what may have seemed to be an accident. So then that unique insight into maybe the critical evolution of exstrophy seemed to lead to your perspective that all the anatomical parts were there if we could construct them anatomically all at once and improve bladder cycling. And what do you think were some of the critical elements then to that anatomic dissection that leads to bladder cycling?
Right. So if you accept that it's a single hit phenomenon, it's just the timing and development when the event took place, and the later in the time of development, the less severe the ultimate exstrophy formation is. So if it's an early event, it's what we call cloacal exstrophy, where the intestine and other abdominal structures are opened, as well as the bladder. And later on, and the least severe is epispadias, and that's just that you lose that membrane later on. What causes that single hit? We don't know. But if the event occurs earlier, then the ultimate formation of would be a cloacal exstrophy, and they're more of a challenge to fix. They're fixable, but more work.
Yeah. Okay. Do we have? Thank you. That was, it's wonderful to hear it in your words from your perspective, which was really one of the defining moments, I think, in our most contemporary understanding of exstrophy. We have a question here in front.
Since we have this panel of experts in front of us, My daughter had a ureterosigmoidostomy in China many years ago, which has worked well up until about 6 months ago, and she's looking at options now to step away from that. So we're looking at what suggestions would come from this panel.
How old is she? 24. And you're having, you're having problems with it? Is that why you have to?
Recurrent pyelonephritis.
Infections, yeah. What do you think, options now?
Well-
And I don't know that we can solve, the exact patient solutions at every panel, but if you could speak broadly about, have you converted any patients from ureterosigs to something else?
Well, I think every one of us here maybe has preference for one type of continent diversion or new bladder. I know in Philadelphia they use the pen pouch, which I used, and it's pretty good, using the part of the ascending part of the intestine. More recently, especially if the ureters are dilated, which I don't know, when the ureters are dilated, the pen pouch is tricky to do. I prefer then to do a Mansura pouch. So there are several techniques that we use depending on the situation, especially if the ureters are normal or not. But the idea is to build a reservoir that is big enough as a recipient for a good amount of urine, so it can stay 3-4 hours dry, and then you catheterize and empty, like any augmentation. But with a little bit more committed, because you don't have anywhere to go if you don't catheterize. So you must be very committed when you do a new bladder. Do a catheterization, releases it. There's no miss. There's nothing, because there is no way to go the bladder and can rupture.
Does anybody else have experience converting ureterosigmoidostomy to a neobladder?
Yeah.
Yeah, we used to do a lot of those. I think the major advantage of undoing a ureterosigs and making a continent reservoir is that you potentially can reduce the potential for infections. But
did you use a certain pouch most commonly, or a certain technique most commonly?
It all depended what was available.
Indiana pouch?
The Indiana pouch.
Well, I was good.
we developed that.
Yeah.
Yeah.
The Indiana pouch
so that's
is
what we
another
did.
technique to
Dr. Mitchell is
transition.
being,
humble.
Yeah, humble. But there is a pouch which they call the Indiana pouch, where I trained. Dr. George Lockhart always felt that, we had the Florida pouch, and the Indiana pouch came in ahead of us. But it's a pouch just like what Dr. Pippi Salle is talking about, using some of the large bowel and some of the end of the small bowel, and creating a pouch, basically, just sort of tailoring it, making it into a circular pouch, and using the end of the ileum, so your small bowel, as a way to catheterize. So you'd have a little stoma, and then you catheterize through that, just like anyone else. But it has advantages, Now, the interesting thing is somebody who has a ureterosigmoidostomy never wants to give it up, because it's low, it's easy, you've done so well your entire life, you're totally continent, and now you're asking them to change, and now you have to catheterize? Like, this is a big change in your lifestyle. And that's very understandable. What I would say, I didn't do nearly as many as him, but when I was training, we were undiverting some. And oftentimes when we'd go there, you would see that there was a beginning of potential problems. You probably heard that ureterosigs can lead to some complications, urine, and that mixing can cause even cancer. You probably heard that. So, but it's very hard to convince somebody that do this. But I think you're thinking about many things, and it's a hard discussion. but there are advantages. You will have a change, but I think there's some advantages in doing that, over the years can add up. And, you want to live 100 more years, and you think long-term, maybe certain things are better than ureterosig.
Other questions from the audience? Yeah, I'll come over there, and then I saw your hand up too.
Thank you. My question is there such a thing as intestine transplant? Because my son has cloacal exstrophy, and most times doctors have said he doesn't have enough intestine to work with. So is there such a thing as intestine transplant? Like, could someone donate? Could I give him some of my intestine? Or that's...
So the question relates to intestinal transplantation. Is that a thing? And the mother said, could she donate some of her intestine to the child? It's a complicated question. Intestinal transplants do exist, but they are not live donor transplants, and they are very complicated, done at probably a few select centers across the U.S., in my opinion. They're not done everywhere. And I don't know all the circumstances that would require you to need an intestinal transplant. It's not done live donor that I'm aware of, unless there's new innovations.
And maybe you're worried about the amount of bowel, but a child with bladder exstrophy is different than cloacal exstrophy. Cloacal exstrophy, length of intestine becomes a concern, because to do an augment, you need a lot of bowel, and in cloacal exstrophy, that you have to do some things to try to create that augmentation. But in bladder exstrophy, you have normal amount of bowel, so you shouldn't worry. The amount of intestine that would be taken for an augmentation will not negatively affect your child. So I think maybe you're worrying about this intestine is going to be used up and will run short, and it won't.
She said cloacal. Did you say cloacal exstrophy or bladder exstrophy? Cloacal. Well, I think before doing an intestinal transplant, there are some procedures that can be done to lengthen the intestine. Somebody with short bowel syndrome, we call. So if you use, I have a case that I'll have to use a piece of bowel. Maybe you're talking about me, because you are my patient, I think. I think we are going to eventually to have to take a piece of bowel. If develop a short bowel, then there are some procedures, like they call the step procedure, to lengthen the bowel, the remaining bowel, to see if they don't make bowel problem with nutrition. I think this should come before bowel transplantation. Huh?
Yeah.
Oh, definitely. I think that because we have a couple kids with cloacal exstrophy who have undergone multiple step procedures, sometimes I think it's harder to use the bowel after that. But the other thing is, just because you have sort of functional short gut, it might not be fully short gut, and you can say, can we work with our intestinal rehabilitation team and to say, how much bowel can we use? And if you say, well, maybe we can use 15 centimeters or 20 centimeters, that will be enough. And sometimes there's also dilation before the stoma, and the bowel gets even stretched, and so you can use a shorter segment. So it's very, very patient dependent.
Can you, okay. Just real quick question. We had our bladder exstrophy down in Texas. Kind of the Dr. Mitchell down there was Dr. Gonzalez, and he believed the same, is doing the complete, reconstruction, except for basically what he called the final step. And he was worried about doing that because of the failure rate at the time. So 11 years later, basically we've had every 2 years we get, we come in, we don't have any infections, we haven't had any problems. We also have a unique situation with autism, so there's not like the same social awareness that there would be, especially nonverbal autism. So the question is now that Dr. Gonzalez is retired, we're coming up on 2 years since he retired, and we're kind of wondering, have we waited too long to do this final step? Are we, what is the panel's opinion on an 11-year-old who had, reconstructive surgery at 3 days old and has been totally fine with no infections, no issues, no nothing, regular checkups, but not ever gone for the final surgery for continence?
Final step, you mean the epispadias has not been corrected? That's what you're saying?
Yes, bladder epispadias was corrected.
Or continence.
No, it's a female.
Oh, I'm sorry. So it's a female patient.
A female.
And had a complete closure, but I don't think a bladder neck reconstruction. No bladder neck reconstruction at that time.
So basically, is there? Yeah. I guess the question was, Dr. Gonzalez didn't want to do that final surgery because we had the unique advantage of having nonverbal autism without that social awareness and that need for that situation. So we waited. He wanted to keep waiting because he wanted the things to get bigger and the growth and all of that. So the question is, have we waited too long, or what is the right time to do that?
I think in a case like that, I don't know if I would be sure that if I did a bladder neck reconstruction, I would be tailoring bladder neck to be sure that I'm not obstructing and she can void, because I don't expect that catheterization would be possible in this particular situation. So I think if you're gonna have to be careful not to tie too much the bladder neck here, and because bladder neck reconstruction is quite difficult sometimes to do exactly right. Sometimes you do a little bit loose, the patient remains incontinent. If you do too tight, it becomes retentive. So there is the midway that is the ideal way to go. But in your case, I don't know, probably I would be very concerned about not tying too much, so because she cannot catheterize, right?
So I think to answer the question,
say something.
I think the one thing to say is I don't think you've waited too long in that she's safe. If she's not getting infections and her kidneys are safe right now, there's no waiting too long, and that's wonderful.
Yeah, I'd agree with that too.
But the determination to do the bladder neck reconstruction would also be dependent on what bladder capacity she has during this time.
Oh, yeah.
And
Exactly.
because it may not have grown as much not having that bladder reconstruction, but it still has potential to grow. So I agree with Dr. Weiss, you haven't waited too long, but the decision to do it would be based on what bladder capacity she would have once reconstructed.
So we as a group have had a lot of conversations surrounding how should we work with the family and the patient for a 10 to 15-year-old patient who still has leakage, and they may or may not have had bladder neck reconstruction as a child. I think that's a really challenging question, but for us, we like to look at the reservoir. Like if you go to towns, you see a lot of water reservoirs and then you see a little outlet, and that's kind of what we need. We need a big reservoir to make sure that there is somewhere that urine can hold for a prolonged period of time. And then number two, I think it's very imperative that the patient is ready to attempt at holding the urine. And that's where pelvic floor physical therapy comes in. And so I think it's very important that the patient is ready to undergo this operation. And then number three, I think it's imperative that before you do any type of surgery, that a surgeon looks at images and with a camera and with dye studies of x-rays to look at the bladder neck. If there is no angulation like you see in those reservoirs and it's just widely open, then we're asking patients to try to hold their urine when their anatomy won't enable them to.
So it's quite likely, though, that the reservoir is not going to be perfect.
Yeah.
You know, you're never going to get to a day where it's perfect if the bladder neck hasn't been reconstructed. So is it not unreasonable then that if it's at least a reasonable size reservoir bladder, to go ahead with the bladder neck reconstruction, to give it a chance to see what its bladder potential is, that Dr. Groth talked about, having sphincter tone and cycling to see what is achievable? Or you will never know. You'll be waiting for something to happen that just ain't going to happen without a reconstruction.
We agree. I think we get hints, like we use medications to see if bladder capacity will increase over time, and sometimes in the operating room we would occlude the outlet to see if the bladder will stretch. We do a lot of these things, but it is a leap of faith sometimes where we trust that the bladder is going to stretch. And admittedly, rarely it does not. And then we have to have tough conversations.
So I would just add, though, I agree with you. You don't know what the capability of the bladder is, right? If you don't have the bladder neck reconstructed, it hasn't cycled, you don't know where it's gonna go. However, with that being said, once you go down that pathway and reconstruct the bladder neck, there are potential consequences, meaning you could go to the other spectrum where you don't empty. You have to do intermittent catheterization. I mean, that's just, the price of continence. But you have to accept that there's no potential going back. Yeah. If for your specific situation, if kidney health, no infections, things like that is the best situation for that specific patient or your case, is you just have to realize that you don't absolutely have to, right? So, but that's just, anyway, that's the side part. Yeah. Yep. Yeah.
Yeah, the disadvantage is you're just losing time. And there's not a cutoff to time, but you're just kicking the can down the road to something that you all ultimately want to know is, can she achieve continence? And you won't know until you do that surgery. And it's a big commitment, but the timing really comes down to your willingness to make a commitment to a surgical procedure and the aftercare with it. And if retention happens, well, there are ways to resolve that, If she's already incontinent now, and maybe you have to do a vesicostomy after the surgery.
No, I think we all agree.
And then you're back to leaking again, but you haven't lost.
Yeah, no, we all agree that there's options for you, but it is a complex case, and each one is different, and we're thinking, I think we're all talking, well, could we do a little bit of Botox? Could we do a little bit of more different anticholinergic medicines if you're taking, it's all individualized. Then we could say, well, you're 11, maybe in a year or two as puberty comes on and the pelvis starts growing, some pelvic floor therapy, you don't need to have a formal bladder neck reconstruction for every child to be continent also, because if the repair is done and things have been brought together, it may turn out that some continence will come as the muscles thicken in that area. And then you just have to do a little bit more. You're already 11, some might say it's a matter of 2-3 years and you're going to know where you sit. And if you're 14, 15 and you're still constantly wet, then there's a certain number of options. There's other options. There's a couple of buckets of options. So I don't feel like you've lost time, certainly not. It all depends when is that correct time, and your child's individual history and the other, coexisting conditions, how that plays into the picture. But no, don't have to run off and do something right now, but it's time to keep thinking about options and meet physicians that specialize in this.
Two more questions from the audience.
Okay, so mine is similar in line with yours. I just want to know how many patients that you all had that was able to achieve continence without undergoing any surgery.
Well, it depends on what the initial diagnosis is. You can reconstruct patients if they don't have the neurologic capacity to void normally. Then even if you do a perfect reconstruction, it'll fail because if they aren't going to do catheterization by themselves, they're in problem. It's a great difficulty.
Yeah, Dana, if you want to comment, and then we'll take our one more question, and then any other questions, maybe some of our panelists will linger around after the meeting to answer some more questions.
So one of the things is that, as we've sort of all discussed before, I think that the surgery has changed over time, and there's very many ways to do it. But if you want to take a single surgery, one CPRE, and wait, when we looked at that before, let's say before 2012, and looked at it, it was 20% who achieved continence, voiding on their own with no other surgery, no nothing, no injections, no nothing. So you say, oh, that's low, but you said it's 20% who didn't need anything else, and that time helped. So now when we fast forward to now, all of our kids are still really young, so I don't think I have an end answer for you. But right now, it's probably around 13% who are, dry voiding 2 hours or more. And if you take 1 hour or more, like we mentioned before, it's 40%. And our hope is that those 1 hour or more are going to grow into 2 hours, and then they'll be there.
Also, I think if it's a girl, you have more chances, no, to get continence, much more, almost double, I guess.
I mean,
it's a boy.
Yeah, if you're telling us to give you numbers, there are patients out there, but for I think universally, I can say that if they're doing like heavy exercise, a lot of movements, they leak a little bit. But it's like living with a little bit of incontinence. A lot of patients are perfectly fine with that.
Great. Let's take our last question from the audience.
Hi. So our son, for a little bit of history, was born, had the procedure that a lot of us have had down at Comer with Dr. Gundetti in Chicago. Last year, he was 6, he underwent the Kelly procedure. I only heard, I think Dr. Groth mentioned Kelly. I was wondering if you guys could speak to any experience you have with that or why it's not as common in the United States. And if the outcomes are kind of similar. Are kind of similar to what we've been discussing.
Sure.
May I ask, so Gundetti did the Kelly? Did Gundetti do the Kelly?
Yes.
And at how old was your child?
6.
It was classic exercise.
So up to age 6, no surgery was done?
Oh no, he had all the surgeries. It was the primary repair.
Okay.
Epispadias.
Okay.
It's classic bladder exstrophy.
And so what was the Kelly for? Was it to gain continence or for the epispadias?
Yes.
I think the guys from UK do the stage Kelly procedure, and the idea behind doing the Kelly is to maximize penile length. They also claim that you reconstruct the sphincter around the bladder outlet. We have still some concerns about, because a major procedure, as you probably know, there are some things, technical things that I think is difficult to talk here, but I wonder, one of the worries that we have is because the penis becomes completely detached from the bone, and therefore it can retract back with time because there is no support to anchor the penis. I've seen 4 patients with Kelly procedure that were done, and the penis that was supposed to be lengthened ended up also with a difficult problem that we didn't discuss much here. The penile length became short as well. So maybe those 4 patients that I've seen were not properly done. It could be that if it's properly done, it doesn't happen. But we are also considering the Kelly procedure, especially for cloacal exstrophies. I think is something that we can maximize the penile length.
Yeah, so we're familiar with the Kelly procedure and the surgeons and the technique, but it doesn't appear at this point to be as, groundbreaking in outcome beyond what we're doing. And we have a philosophy and a standardization of a technique that we're trying to perfect and optimize. And so to stick with a philosophy that we've started with and follow through is important, but we are open to, major innovations. And with time, if the Kelly bears out elements that we can incorporate, I think we will. But I don't think we've come to that point yet.
Yeah, we had a spirited conversation about it yesterday.
Yeah.
So we know the Kelly very well. We know the people who are doing it, mainly at Great Ormond Street and in Brazil, in Chile, and in Europe, in France. You're right, it is more common outside of the United States, a lot because somebody sitting here on the stage has been very influential in sort of training all of us. So that creates a bias that we like the CPRE. We're very open. We see advantages to the Kelly. So I would not want you to think that your son got a wrong operation. It's very much an accepted. There's the Hopkins way, the stage repair, the modern stage repair. There's a CPRE that we all, it just happen to be, there's a Toronto approach. He has a modification of that. And there's Kelly. So, these are all legitimate, very good operations that are safe, done well. However, we don't know if one is better than the other. So we've sort of taken the line that we're perfecting an operation that we're doing more commonly, and making it more reproducible, finding if there's these, subtle changes that we can make and active changes that might improve some of the things that we want. We're all interested in more length for boys. We're interested in continence for everyone. We're interested in sexual function and all of those things. So I think you did the right thing. We didn't talk about it as much because we honestly don't do it as much in the U.S. But there are a few people that are coming, that are going to do more Kelly. So we'll be talking more about Kelly in the U.S., but it's just not as common.
Thanks.
It's hard to make comparison between the techniques because the numbers are small, the patients are different, so this is a heterogeneous population, all of them. So it's very hard to claim that one technique is better than the other. We do that in Congress. We discuss a lot, but I don't think we have the answer.
All right, thanks. Thanks for your expertise, your willingness to be up on the panel and sharing it with our audience and your presentations today. We're going to end the panel, and then I'm going to give the final word to Pam for closure adjournment of the meeting. But I just want to thank all of you for being here. It was a tremendous turnout, and your commitment to ABC and to coming to meetings and allowing us to communicate with you and share with us your experiences is invaluable, and it inspires us to be better at what we do and to keep working hard at what we do. And so I appreciate it. I think this was a great meeting. I have so many people to thank, and I'll keep it short, but again, the fabulous Heather next door has done a spectacular job with the children, and I think she kept them engaged and safe to the best of my knowledge. I did not see any ambulance arrive here at the building, so don't forget your children, though, either. Make sure you pick them up, because I do not want to take them home with me tonight. Thank you to our fabulous audiovisual gentleman in the back. It was seamless today. And I didn't even notice audiovisual was an issue. And that's how good it was. It was just so good. And thank you again to those who traveled. Dr. Pippi, Salle, who came from Canada, some of you who came from out of the country, our colleagues from Boston and Philadelphia who took their weekend to spend it with us and share with you guys their expertise. And my own colleagues, Dr. Groth and Dr. Roth. And you haven't meant Dr. Troth, but I make sure all my colleagues rhyme. So it keeps them straight in my head that way. And to Colleen Rosen, who I haven't announced, but she is our nurse practitioner for longer than I've been here with dedication to Exstrophy, and she keeps those day-to-day questions, answered for your families as they come in, and her expertise is equally important to the management of the things we do surgically. And Pam, of course, you and your ABC team were very proud to have sponsored the meeting this year. I hope you all enjoy Milwaukee while you're here, a new experience for some of you. And I hope you get to see the best of what we have. And Pam, if you'd like to come up and close.
Well, thank you, Dr. Krieger. We have really enjoyed working with your team this year. You made it so easy for us, and I think this is one of the largest groups we've seen in a long time, so I really appreciate all of you coming and traveling. We will be sending out a survey in the next couple of days. Please fill it out. We take everything that you tell us seriously. It helps us prepare for the conference for next year. Dr. Lee's here from Boston. They'll be sponsoring the conference next summer in Boston. We're still looking for a hotel, but so we'll be announcing the date soon, but we started about 6 months ago looking for a place. So we've been actively already planning for next year. So we hope to see all of you there. Please feel free to roam around. Have a great time at the fair. Take pictures and pick up your kids. Thank you all.